that
All right, good morning, everyone. We're getting started a few minutes late. I hate to interrupt the sidebar chatter because it sounds like it's productive sidebar chatter. Good morning, everyone. For the record, I'm Colette Peters, Director of the Department of Corrections and also Chair of this work group. Welcome, everyone, to our final work group meeting. I am so appreciative of all of you hanging in there with us and having what I think has been a really productive time and conversation. We'll start as we traditionally have done with introductions. So if we could just go around the dais. Senator, would you mind starting?
Senator Jackie Winters from District 10. Not much of a voice this morning.
That's not good.
Well, I think it's just, I was in D.C. and I know my fellow physician to my left was also in D.C. and it's always airline travel.
Yeah, they can wipe you out.
Yeah.
Well,
And it was health care too, by the way.
for both of you.
Yeah.
All right, well, welcome back. Doctor?
Norwood Knight Richardson. I am Senior Vice President at OHSU, the President's Office, and Senior Vice Chairman of the Department of Psychiatry.
Mary Beth can ask me.
Director?
Fairborse, Paxuresh, Oregon Youth Authority.
Good morning, Washington County Sheriff Pat Garrett.
Carl Miller, OSP and AOCE Vice President.
Great, thank you. So first I would like to cover the background of the work group, which covers the report, introduction here, and work group charge and process, all of which can be found on page 4 in the report. So just for the record, I'm going to back up. I know that you all know this, but I think it's important to pause right now and recognize that we have someone on the telephone. Thank you, Mr. Shoemaker. Julie, would you introduce yourself?
Sure. My name is Julie McFadden, and I'm legislative aide for Senator Bates, and apologize for not being able to be here. He's vacation.
We understand, and we appreciate him staying apprised through you, so thank you so much. So, as you know, Senate Bill 843 created a work group to address the rising healthcare costs within the Oregon Department of Corrections. So, under the direction of the governor, this work group was tasked with recommending legislation. Good morning, welcome. To lower the healthcare costs of the Department of Corrections. And as you remember, we were on quite the trajectory of spending years ago before we implemented many changes at DOC, which we have talked about. The legislature asked the work group to prioritize legislative concepts that, 1, produce the greatest value for the department's healthcare expenditures, 2, potentially consolidate healthcare functions as appropriate, and 3, integrate into other initiatives in the state to reduce healthcare costs. So we met various times, and while we varied the agenda briefly, the format generally remained the same by providing follow-up from the inquiries previously requested, reviewing recommendations and next steps, and providing agenda items for the next meeting. As summary of each meeting is presented on pages 5 and 6 of the report. As outlined on page 7 of the report, the total work group offered 15 cost-saving recommendations for the Department of Corrections consideration. Let's look at those and recap each one of those individually now. And I'll pause. We have a work group member that just joined us. We've already done introductions, if you don't mind.
I'm sorry for my late arrival. It's Celia Howes on behalf of the Oregon Criminal Defense Lawyers Association.
We're glad you're here, Ms. Howes. Thank you.
you.
And please, I want this to be an informal conversation as it has been in the past, so please interject the changes as you would like to make the recommendations. I will reiterate that the draft that you reviewed prior to coming here was a draft report, so we really want to make sure that the language that's finalized today really reflects the conversations that we've been having for a year now. So implement an electronic health record system that best fits the needs of the department. You can find this on page 8 of the final, what will become the final report. As you know, the department is moving forward with this recommendation. A consulting firm is assisting the agency in clearly defining our needs and will help in developing the actual RFP for this request. The RFP is anticipated to be complete during the first quarter of 2015, and the department has also submitted a policy option package to the governor with our 15-17 agency request budget that asks for $3 million in initial startup least serviced cost. So our plan, as we've done our research, is to lease a system as opposed to purchasing one. So before I move on to the next recommendation, Doctor, I know for certain you have some changes that you would like made to this. I will turn it over to you first, and then we can hear from others.
Thank you, Madam Chair. My comment was in reading this, is that we be sure that the system we lease or purchase, if that turns out to be, is a system that can talk with the key partners in the community. And it states in the summary that best fits the needs of the department. It's not just the needs of the department specifically, it truly is the needs of all of the healthcare providers, the people that may currently be in the DOC, but will surely, hopefully, someday be in the community. And even while in the DOC, will be using services in the community so conversations need to happen over the electronic medical record. And as I was speaking with you, this need not be as complicated as an Epic system which allows you to order medications and to order other laboratories. That could be helpful, but I think the essential part is that the information regarding what has been done, tested, treatment results, et cetera, be able to be shared between the entities. I just think that's a sine qua non and essential of any electronic medical record.
Agreed, and for the record, I'm nodding emphatically. As I said to the doctor before the meeting, we don't intend to purchase a product that doesn't do that, because I think the efficiencies that would be gained would be incredibly dramatic, both from a cost perspective and from a healthcare perspective. I think about, Sheriff, the number of tests you do when they're in lockup. And if those files don't come immediately, we're repeating those at intake, right? Let alone once they hit the streets and unfortunately commit a new crime, end up back in your jail. For you to have access to the medical, mental health records during their stay with us, it would be an incredible asset. And finally, as everyone leaves our system, I think the research says 99.9% of them will be eligible for Medicaid or Medicare now. Having that connection is going to be incredibly important. So we will work on language that you'll get to review again before we stamp approval. That will include more stronger language around that important piece.
And
Senator?
for me, I think it's extremely important because we have so many not too good results with IT breath checks, that the business plan and what's developed is developed so that both from a management standpoint and from a legislative standpoint, that all the I's have been dotted and T's have been crossed. I can't tell you how nervous this body gets when we talk IT. And so I would strongly recommend, if that isn't happening, that, while you're developing your business plan, that you develop it in concert with the IT staff, with both legislative, fiscal, and DAS, so that we don't run into problems later.
Fair enough. Thank you, Senator. And we can make reference to that in the report as well. Ms. Bodkin.
I guess I just want to be sure that the systems are going to talk to each other. And I just want to underscore what the good doctor said, because my frustration, just on a personal level, is that Seventh-day Adventists can't talk to Providence. My primary care physician is an Adventist doc. My neurologist is a Providence doc. They can't talk to each other. And if they can't talk to each other, how are we going to make sure that 36 county sheriffs can talk to DOC and vice versa, and access outside medical records that may be critical to the proper treatment of the inmate once they get into our system, and that our medical staff have access to all that sort of minutia information that may not be critical on a daily basis, but could be critical on a long-term basis. And I just don't, I have concerns about whether or not it's in the medical community's best interest to make sure we can all talk to each other. And I agree with the good senator, you know, anything that has IT after it scares the devil out of me. I'm not seeing this, you know.
I think the conversation becomes you know, when you start talking about the external systems. And I'm fully aware that even here, hospitals and the docs, they're incompatible in some of the systems that have been designed. I think for us, it kind of begs the question of how broadly do we want this, and whether it's the ability to have the communication within our systems. You know, looking at the county jails and looking at DOC, so that we've got a conduit between those that work that gap. Because what you're talking about will take a lot more, I think, resources and what have you, if we're talking about hospitals and docs and everybody else. Because honestly, they're not compatible. And they haven't been compatible since we first started talking about IT. It's not just your area and your providers, but it's the same here in Salem. But I think for our task, I thought, and correct me if I'm wrong, we're talking about making certain that information is available and what have you through those channels that we're working with.
Yes,
Am I correct?
yes.
Great, thank you. Anything else on this recommendation? Okay, then moving on to introduce legislative remedies for House Bill 2087 to enable suspension versus termination of medical eligibility. So in great collaboration and in concert with the OHA and the Department of Justice, the Department of Corrections submitted a legislative concept for consideration during the 2015 session. The language was drafted and the concept was submitted this July. So we've adopted this recommendation, it's underway, and is moving forward in a legislative concept. Any questions or concerns? Create a case management program with health classifications and clinical guidelines. So the Department of Corrections, we are already doing this for off-site care, and DOC is now exploring how we can do it internally. This may require additional staff, so there may be additional resources required on the front end to implement something that would produce more efficiencies and effectiveness on the back end. So we're reviewing the options for multidisciplinary teams to review clinical plans for patients with acute needs. Just as a reminder, DOC Health Services currently has approximately 50 positions vacant, some because we can't fill them because they're in the rural areas, but primarily to manage to the $37 million hole that we have right now.
50 positions?
50
How are
positions.
those stratified? Guards?
No, these would all be health services.
services, okay.
Positions, all health services.
And-
So we have far more positions vacant across the agency, but just in health services alone. And I will tell you that health services has a disproportionate number of vacancies, so they're really filling that hole to a greater degree because the correctional officers, we have mandatory posts that have to be filled.
It might be helpful that in a part of the narrative in the report that we point out the issue of vacancies in the rural area, because I believe that rural health is also having some discussion as to what should we or what can we do legislatively about this whole issue of providing the adequate resources for the rural communities. Whether we incentivize or whatever. So for me, I think that just pointing it out, because I know rural health is also, you know, having this conversation, both from the standpoint, you know, and all of it, not all of it, let me rephrase, that the medical needs are probably greatest of trying to recruit and get individuals, you know, to go to Ontario or any other place in the world.
Lakeview.
Or Lakeview. So,
Yes. Great, we will add that. Thank you, Senator. Ms. House?
Along the same lines, is it within our purview to recommend that those jobs be eligible for some sort of loan forgiveness, or is that already happening for practitioners who have medical education loans?
So that is not something that's already
Okay.
happening. I don't know if that would require legislation. Yes, our
It
council
would.
is saying yes.
Didn't we try that with OSH to a dismal failure? I thought we tried doing some partnering with OHSU on psychiatric treatment for OSH physicians with some loan forgiveness. And my memory banks tell me that it didn't work well. But I don't know the answer to that from you of the physicians who work there 24/7 versus the ones who sort of come in.
From the stand,
I don't recall, Doctor.
from the standpoint of OHSU, it has worked well. We filled all of the slots where that was available. That was in general medicine. As far as psychiatry is concerned, we really haven't had to use that because we've been so successful in recruiting physicians. I think I've recruited upwards of 40 psychiatrists over the time that we've had the relationship with the state hospital. We currently have approximately, I think, 21 or 22. I lose count because there's some in the pipeline. But no, it has been successful.
Yeah, I don't know how we get folks to move to Ontario and
That's
to
another one.
Lakeview and,
That's right.
you know.
Well, may I?
Yes, and I will point, Director Paksaresh is reminding me that down in our recommendations, we actually have a recommendation to explore incentives around hiring.
Right,
But it's
right.
an exploration incentive, so maybe we can include, when we get to that point, a specific exploration around loan forgiveness.
Right.
And I think one of the essential elements of keeping these positions filled is that there is a pool of individuals, and when you hire them on, they have the prospect of rotating. And that's precisely what we have done with our state hospital doctors. They have the option of rotating after 5 years or less, depending on what the needs are, to some other duty. And when you start attracting people to these places like that, very often we recruit in hopes that they will stay there forever, but that's generally not the case, especially if they're recent graduates. But you offer them the opportunity of rotating, and in partnership with other institutions, including academic institutions and general allopathic hospitals, you may be able to offer them a rotation to some other place after a certain amount of services. And that way you keep a pool going, and that's precisely what has happened with
Okay.
us.
Great.
So, and I'm happy to talk with you more about that in detail. But I think that is going to be the key.
Okay, great. So let's include that in our recommendations down the road here. Okay, thank you. Anything else? Okay, exploring the prison to community connection for all aspects of healthcare. When we discussed this, the discussion primarily focused on the importance of uninterrupted public assistance for adults in custody transitioning into the community. The department is currently applying for Medicaid on behalf of inmates preparing for release. We did submit a policy option package for one additional body to help us manage this process in the long term. Right now, we've pulled resources from another part of this agency to work on this new project, and we found that it is a full-time position. So that has been submitted to the governor. Hopefully that will move on and be submitted to the legislature as well. Ms. House?
Thank you. I have a question that I may have asked in previous sessions, but I'm curious as to how this recommendation and policy package dovetails with the administration of the community care organizations. It's my experience right now. I've got several clients, mostly in the federal system, but who are out on pretrial supervision or post-prison supervision, who are receiving services in a county that's not their primary residence county, and they're struggling to, for example, combine drug treatment with mental health services because of the operation of the community care organization and the preference for the provider and the community of residents. Okay. I am no expert on how those community care organizations work, and so it's more of a question to this group as to what people are seeing in their own particular practices and how our recommendation can make sure that that's run most efficiently so that there is that continuity of care across the types of services that need to be provided.
Well, Mr. Shoemaker might be able to go deeper than I can. I know Mr. Robbins could. What I can say from our perspective, the good news is in Oregon, almost without exception, when you leave prison, you go back to your county of origin. It's in statute. So it would require an override and a reason for it to happen otherwise. And it does on occasion. There's no doubt. No, but on a case-by-case basis,
That's what
it
I
can
mean.
change, yeah. And so I know that from OHA's perspective, their vision, I think, with the Department of Corrections is a great one. I don't know that we're fully there yet, but their intent is to help us get to the place where CCOs are actually reaching in prior to release. And so we're hoping that when it's fully up to speed, that transition is very smooth and those connections happen before they leave the prison gate.
Okay.
And we have been, and I know some other states are trying, and some of them, there's some roadblocks, so I don't want to kind of highlight too much because I understand that there is federally some conversation about this, and so far we're ahead. And we've been proactive on this issue and recognizing that the CCOs, particularly when we've combined physical and behavioral health, also are in the process of trying very hard to actually come together with those two strategies, and it's not easy. And I think those of us on policy side want to give them the chance to kind of iron out the wrinkles and what have you. So I think probably each CCO across the state is at a different stage in the development and the delivery of services, both for the non-prison population as well as for the general population.
And just to put sort of a finer point on the observation I've been making is where you see inmates, to be or inmates have been needing to leave their community of origin for a particular kind of service. For example, residential drug treatment or specialty mental health services.
Not that they're living in a different county.
Not that they're living in a different county, but they, have some kind of halfway house residential treatment option that's only available to them outside of their county of origin. So they travel to receive that service, but while there, they have a cardiac issue, or while there, they need mental health services that are apart from drug treatment, or, things of that nature. And there's a real impediment to receiving those services across the board. So it may not be something to take any action on right now, but just sort of raise the issue as something that's that is creating a barrier in the community.
Thank you for that clarification. I don't think I was understanding.
Yeah, and perhaps that conversation should be held with the Oregon Health Authority. Because if it exists for them, it exists for the general population.
Right.
And so it's not unique to our population, but it would probably be something that still needs to be hammered out between the Oregon Health Authority, and I see they're not here today, but that would be one that we can actually share.
No doubt, we can share. And Sheriff, I don't know, from a community corrections perspective, I'm not hearing anything specific out of Douglas and Lynn County. I don't know if you have any observations out of Washington.
I haven't heard that. Did you indicate that was unique to the federal system or federal and state?
No, I'm seeing that both with people who are not in the criminal justice system, like the senator said, just in the community, who have actually been contacting me saying, what do we do about this? And also, I specifically, I have a couple of clients who are experiencing that issue because they're on federal pretrial and leaving their county of residence for inpatient drug treatment services, but they have a dual diagnosis, they need mental health treatment, it's not provided by inpatient drug treatment, and so they need that connect with a mental health physician but are not getting it.
Okay.
The federal conversation is taking place.
Okay.
And it's taking place as to whether or not the ACA is going to allow that reimbursement. I was just back in Washington, so I know that conversation is being had with, I didn't know you were talking to federal things, but you might want to talk to somebody who's more in touch with what's going on with respect to the not holders leaving, but somebody's replacing. That is a topic of discussion right now at the national level.
Right.
I might just add one more thing. What's enabled us to have much more capacity for wraparound intensive supervision services in health services is the House Bill 3194 Justice Reinvestment Funds, particularly in the urban area, where we're able to, in a very local, kind of inter-county setting, have those kinds of services available to folks that are coming out of prison into the local community for supervision, as well as coming out of the jail. And Senator Winters knows better than all of us the work that went into making that a reality, and that's really, really helping us out at the local level. Now, the prison population was hovering a little bit below the projected 3194 levels. Now it's a little bit above, so we're just keeping a really close eye on it. But those services are really helping us out a great deal.
Great.
Great, thank you, Shara. And while the vice chair couldn't join us, he had a family emergency. We do have someone here from OHA. Brian, I don't know if you want to add anything to the conversation, but feel free to come on up.
Brian Ebert, Legislative Coordinator for Healthcare Programs with the Oregon Health Authority. I'd certainly love to have a discussion with you after. I mean, I wish there was a clear solution to all those problems, but some of them are really individual. And I'd be happy to talk with you.
Great, thank you.
And see if we can't resolve some of those issues. We have, enrollment situations like that, but we can usually fix them, so.
Great, thank you.
But for clarity's sake, she mentioned federal. And there's clear distinction for Medicaid responsibility that's state versus I need to put that on record, versus federal. So just for point of clarity, I don't want somebody calling me with a federal issue.
Yes, ma'am. I'd also be happy to put you in touch with Director Samuels, who's the director.
Great. Fantastic.
That oversees the Bureau of Prisons.
Great.
Okay, so if you want to connect with me via email, we can pose those questions.
Great,
All right,
thanks.
thank you. Thank you.
Sorry to interrupt, this is Julie. I'm just having a really hard time hearing Brian. So.
Oh, okay, great. Essentially what he said is these sound like issues that are more on a case-by-case basis as opposed to overall arching issues from his perspective. And so he's going to connect with Ms. Howes and figure out if they can solve those problems individually.
And
Fantastic, thank you.
if it is a pattern that we're not aware of, we'll certainly look into how to address that.
Great.
So let's
Great.
connect after the meeting and
Fantastic,
and I'll
because
work
some
on
of the
it.
patterns are unrelated to the correction system, so I'll save this group from that discussion.
Perfect, great, thank you. I will
All
say, just for the record, the collaboration that we've received with OHA has just been exceptional. Exceptional, so,
Great.
thank you. All right, anything else on that issue? Conduct a nutritional review of food and associated costs. So in December 2013, the department asked the Association of State Correctional Administrators to come to Oregon and review the cost of its food services program to see if there was room for improvement. This has been something that has been discussed over and over again over the 10 years that I've been with the agency. So both because of conversations we were having with the sheriffs and this group, and the fact that we've been having this conversation for quite some time, we asked this organization to come in, just some external eyes, to see if there were things that we weren't seeing that they could bring to light. And they did find some. So upon reviewing 8 key areas, ASCA concluded that overall we were operating a successful food service operation. And we specifically asked them if there was any improvement to be gained around outsourcing the food services program. We actually talked to an organization that I think is successfully doing it in Washington County, and they confirmed for us that unless we were to dramatically drop the food quality inside our prisons, that they would not be able to deliver that food service from a private contracting perspective at the Department of Corrections. ASCA confirmed that as well. They said that the food quality in Oregon is part of our culture, no doubt. And it is. I think, Sheriff, you and I have talked about this offline. But they did have several recommendations that they believe will improve the cost of our food delivery. And that included the adoption of 2 master cycle menus instead of 4. And an analysis of whether or not the current baseline budget was realistic in comparison to the budget allocation. A determination of the healthcare costs avoided because of this change would include establishing a baseline of current healthcare costs and review and analysis of costs in the future. The difficulty here is that we don't have an electronic health records yet, so understanding the health of the 14,600 individuals in our custody in the aggregate is impossible at this point. But that is something that we will continue to review.
Did they look at security issues when you changed this up? I mean,
They did. They did.
you and I know that, I mean, well, all of us who work in this
As in
area.
disgruntled?
You know, there's two things that keep inmates happy, mail and food.
That's
You know?
true.
And if you mess with mail or food, you're gonna have problems in the prison.
That's right.
And so, you know, was there any sort of analysis done about future security issues because of mixing up their food?
There was, no doubt. And in fact, that's why I think they pulled off the notion of outsourcing it, because they did recognize that the quality was so high. And we did have concerns about going from 4 cycled menus to 2. And officer, you're welcome to join in. So we said that we would pilot this and see if there were any concerns from a security perspective, because you're absolutely right. Food matters. And I've discussed with this committee before, we dialed down sodium over a year's time so that it could slowly be moved in without notice. And so any changes to food, as you are all acknowledging, and I appreciate that, is a very difficult one. Officer Miller, anything you want to add from a security perspective?
Yeah, I think it's pretty well been covered. It's like you mess with it and they get pretty upset. We receive complaints all the time about portion size and everything. It is, they're not making the healthiest choices, you know, but if you make them for them, then it becomes an issue of control and whether they'll rebel and lash out at you.
Thank you. Any other comments, concerns, Director?
Just a quick comment, it's great to have outside perspective and knowing that you're doing things right. So that's great.
Great, thank you. Okay, the next one segues into Officer Miller's comments, where often they're not making the best choices. Exploring providing healthier food options through commissary and the associated impacts to healthcare, as well as the safety and security of our prisons. So the department shared information on menu modifications that mark heart-healthy choices. Broadcasting heart-healthy snack videos, developing and providing carbohydrate counts, distributing nutrition articles in the inmate newsletters, and developing gender-appropriate caloric menus, and removing fryers from institution kitchens. Limitations to commissary have the potential to negatively impact safety and security of their prisons, which can actually have a negative impact on the budget. And so this is a difficult conversation, there's no doubt about it, because we can provide 3 very healthy meals a day, and if they have 12 servings of ramen in their cell or candy bars, it just wipes out everything that we've done, right? And so we really had this some pretty heated conversations at the Department of Corrections around the ability to take away things from the commissary. And some of the issues that we found from a security perspective is we have increased the cost of candy bars over the years, right? As an example, they've moved from $0.25 to $1.25, and we haven't increased PRAS points since they were created in 1998. And so they're having to spend more while receiving less. It was 1998, right, Mr. Van Valkenburg? Do I have that right? I'm not sure. Okay. And so taking away from the commissary list was one that we weren't willing to do from a security perspective, and so we're trying to go at it from an education perspective. And really, that's what matters, right? As we're having the safety and wellness conversation with our staff, the doctors that are consulting with us to come up with a wellness program for our staff say very clearly, until that person sitting in front of you decides to change their behavior, you can make all the all the education videos that you want, and it really has to be internal. And so we're trying to do that for the inmate population as well, is really get some education out there around their health and wellness while they're in our care and custody. Ms. House?
Is it impractical or not cost effective to add more healthy options on the commissary list? Like, for example, more fresh fruits and vegetables, fresh carrots, things of that nature, hummus, things that are going to be less in sodium and actually be what I call, for my children, growing food.
Right. So we are exploring that to some degree. Preserving things on the commissary is difficult. We usually do not have very many refrigerated items or frozen items, although we do have some. So we are exploring that. We've added additional healthy choices. Again, as I walk through our commissary, what I learned from our staff is that while we provide things like baked Lays, those die on the shelf and expire, and the regular potato chips keep coming off. Right? And so again, it's really, we are going to do that, and we are going to do things like take the fryers out of the kitchen and not have that as an option anymore. But it really is going to have to be an education component with those in our care and custody. So we'll do both.
Great.
There's
Officer
a
Miller?
mentality, if you try to make the choice for them and you try to take it away from them, they see it as a takeaway and they rebel against it. You're not gonna, you can't get the inmates to make the healthy choices unless they want to do it on their own. If you try to force it, then you end up in a situation where you're gonna end up in a confrontation and
Sure.
and them acting out, and sometimes potentially catastrophically.
I raised the point about the fresh fruits and vegetables, and now I'm speaking about the county jail level. So this is again not specific to DOC, but I've got a lot of clients who will just talk to me about their cravings for fresh fruits and vegetables, that they're sort of done with beans and rice, et cetera, at the mealtime, and they wish they had something
Which
fresh at
county are
the
you
commissary
in?
level. I'm in Multnomah County, but we practice all around the state. So, again, it may just be completely practical to have a refrigeration system at the commissary level, but that is something I think that, it's not making a choice for them, it's giving them more options, but it may not be cost effective, so.
Well, and no doubt, and I hear that from the inmate population, especially our women, who want access to
Right.
more fresh fruits and vegetables. The other thing that we've done in the last 2 years is we now have garden programs back up and running at all of our prisons. And so we're able to supplement what we would have spent on purchasing vegetables, and we have more fresh produce readily available on site that the inmates have actually harvested. And so it's an all-around productive program that has introduced more fresh vegetables, even as opposed to frozen vegetables,
Right.
into our institution. And since I get to be on the soapbox for a minute, and it's also allowed us to partner with local food pantries for any of the extra produce that we have, then we're sharing with the local community.
Great.
Anything else?
Another impediment for the fresh fruit side or any perishables is that we're moving all our canteens now to a bagging system from Central. And so stuff needs to be able to go into the bag and survive, a day or two before it actually gets to the inmates.
Right.
So,
We're hoping that we'll have more, well, I know it's a culture change and
a lot of complaints.
and a lot of concerns from staff and the inmate population. We're hoping that it becomes a more effective and efficient operation. Did we have somebody else join us on the line?
Yeah, this is Jennifer Williamson.
Hi, Representative Williamson, welcome.
Hi, thank you.
We were just discussing commissary, which I know is one of the issues that's near and dear to your heart. How much of the conversation did you hear?
I just came on.
You just came on. Okay, so I'll back up since this is one of the issues that you were really interested in. So we are making some changes at the Department of Corrections. The changes do not include removing options from the commissary list, Representative, for safety and security reasons. We didn't want to engage in takeaways, primarily because That list is far more expensive today than it was in 1998 when we adjusted what the pay they would receive for the jobs that they work inside our institutions. And so removing things from the commissary would be considered a takeaway, and we have security concerns. What we are doing is we're providing menu modifications for more heart smart, healthy options. But more importantly, we're trying to do some very serious inmate education around healthy snacks. We're actually broadcasting heart healthy snack videos and developing and providing carbohydrate counts so they actually know what they're consuming. We're distributing nutritional articles in the inmate newsletters. We have a great program at Coffee Creek right now in collaboration with Multnomah County Public Health, who's helped us with this, developing a gender appropriate meal at Coffee Creek. And we are removing fryers from all of our institution kitchens. And then there was lots of dialogue around the possibility of increasing fruits and vegetables and some of the things we're doing now that we have gardens back up at all of our prisons.
That's great, thank you.
You're welcome. Anything else from the committee on this issue? Okay, moving on then to exploring mental health intervention to prevent incarceration, including mental health courts for both the Department of Corrections and OYA populations. This is an issue that was inside the purview of the work group, but we did not want to duplicate efforts. And this is one that has been assigned to the Specialty Courts Subcommittee of the Public Safety Task Force. So we pulled back on that. The senator is chairing that subcommittee, and we know that this topic is in good hands. Any concerns, questions? Okay. Proposing legislation to prohibit insurance companies from terminating insurance coverage while individuals are incarcerated in state prison and also in county jails. This was born out of House Bill 4110, and this recommendation was reviewed by the department in the context of applying the concept to the entire prison population, not just pretrial custody. The department looked to the counties for direction on how they plan to implement the bill. But what we learned is counties are still grappling with how to do this. This concept would require the department to create a new unit assigned with the task of providing billing services. So this would mean additional FTE and a function that doesn't currently exist, and something that we have no experience in. It would also require that we have an electronic health record system to begin with. And so our recommendation is that we delay this conversation until the counties have had a chance to implement 4110, until we get an electronic health record system up and running, and then reassess the viability of moving forward. Any objections to that or changes to the write-up? Okay. The next one, consider legislatively mandated exercise programs. So we did survey all states and major municipalities, and it was determined that no prison system that responded had implemented a mandatory exercise program due to custody considerations and the cost for staff and implementation. I think also that whole notion of mandating something to the inmate population from a security perspective was a concern. The department provides many voluntary exercise options, and a sample of these were provided to the work group, so you remember that list was very long. So our recommendation is that we continue with voluntary. We're hoping that the education that we're providing around food and healthy choices there will kind of swirl into an education for the inmate population around exercise as well. This won't require legislative action. We can do that internal to the department and make it a priority from that perspective.
Would you provide as an example, and I just heard about the run, the 10K run.
Yes.
Yes.
Yeah.
And, I would put some examples in the report that actually is currently going on inside the prison. I had an individual who contacted me who was so excited when they learned that this was taking place. And I think so often that we don't know, remember, the public also will read this document, and this person was someone from the public who really actually sent me the link.
To the newspaper article?
Yes, because they were very, very excited. They actually went.
They
were-
actually ran.
They ran. And so I think that, those kinds of examples of what is taking place is also beneficial, so I would-
Right, thank you. And that was at the state penitentiary here
Yes.
in Salem, and it was, I can't remember if it was a 5K or a 10K.
Yeah.
But the inmate population participated alongside the community, and so it did a couple of things. One, it highlighted the importance of health and exercise, but two, that community connectedness is so important. You have heard me talk about that time and time again. And not only is it important in terms of the safety and security of our prisons, because the officer I know will tell us that if they're planning to participate in a program like that, they're not going to get in a fight in the yard that week, right? But now research tells us that it actually reduces recidivism. The Department of Corrections in Minnesota actually studied what reduces recidivism, and the thing that rose to the top of the list was if they were receiving visits from people in the community. And so
It
this,
didn't matter if it was family or not.
it didn't, right?
That's right.
It mattered
Just-
more if it was family, but it was still statistically significant if it was not.
That's right.
That's right. And so that's something that I won't digress, but that's something we've really worked on over the last 2 years as well. And this race contributed to that, there's no doubt about it. So we can revise the report to include the list of programs that are afforded across the department and highlight some of those. Okay? Anything else? Great, thank you. Okay, moving on to one of our more lively conversations, which was the recommendation to analyze possible early parole release restructure. The Board of Parole has adopted administrative rules governing early medical release as required by statute. We reviewed those as a work group. Expansion of early medical release by virtue of certain initiated sentencing measures, such as Measure 11, would require legislation. We are all very aware of that. It would require passing a supermajority of both houses due to the Oregon constitutional restraints. To the work group concluded, and I think we have some work to do on the draft report. The work group concluded that this is not something that they wanted to recommend legislatively at this time because of a variety of reasons. I think on its surface, it looked like a good idea, right? Especially as I bring forward poster child examples like the quadriplegic that I have that costs $50,000 a month, right? But he's a sex offender. And the complications of releasing someone like that early into the community seemed great from the perspective of this work group. And at the end of the day, it didn't fit, as the sheriff pointed out at the last meeting, one of our primary charges, which is to make recommendations that would significantly alter the cost of corrections, the cost of healthcare in corrections. And so DA Sparks actually sent a really thoughtful email to the committee. I don't know if you've all reviewed it. And it included some amended changes where as you look at the report and the first paragraph, what he's recommending is we actually strike the last sentence of that paragraph, insert a sentence that says such legislation is not recommended by the work group. Under recommendation, strike under consideration. And I think why we put this in the draft report is, Senator, I think you said at the last committee meeting that if we were to do something like this, it would require more conversation.
Yes.
But I think that it's very clear, and please feel free to object. I think it was very clear from this work group that while someone else may have that conversation down the road, this work group was not recommending proposed change. And so I think it makes sense to change that from under consideration to no change, as DA Sparks is recommending. Again, to strike possible reassessment and to substitute that implementation with none, and under legislative action, striking required if action taken and substituting it with none. So please, work group, tell me if I'm misunderstanding the conclusion from this work group, or if you're disagreeing with DA Sparks' recommendations or have any other changes to this, what I think was a very thoughtful conversation.
Madam Chairman, I agree with what you suggest. That was a contemplation that I had. And I had the question of what do you mean by under consideration because of the very complexities that you just outlined. So I would definitely support your recommendation.
Right, Senator?
And just actually after the presentation from the Pro Board and looking at what currently the rules are, and I know that my colleague, I still call her my colleague.
I am your colleague.
Yes, and even though you're, anyway.
Her retirement was announced
That's a
publicly
whole
this
nother
morning.
conversation that I'm gonna have.
For those of you that didn't know.
That does not mean that we won't continue to have the conversation with respect to the issue that you and I.
I still have it on my workload for almost another year, so,
Last I said, you and I have
Yeah.
not, yes.
Yep.
Director?
Who knows what happens after that?
I agree that, under implementation and legislative action, no action are anticipated on those two fronts. But I think under recommendation, as the Senator just pointed out, we never want to stop the conversation.
Right.
So I think rather than saying none, I think it would be helpful to say further conversation is required
Yeah.
to explore possibilities that exist on that front. In the case of the quadriplegic that you mentioned, Director Peters, I think, I understand, the emotional issues that exist around there and, sensitivity to victims. But, if that individual has no probability of offending, and if it's costing us $50,000 a month, then would it be something that we at least want to have a conversation about? We're not proposing a change at this point. So I think, leaving the door open to consider future options, even though we do not want to make a change at this time, I think creates a balance that indicates we should be looking into some of those situations that would make sense.
I thought that under implementation, where it says possible reassessment, left that door open. That may or may not speak to your point, but that was what I thought that the way that was phrased aloud. Am I misinterpreting that?
I think that was the original
was the intent.
intent based on the senator's comments at the last meeting.
Right, to leave that, just what you said.
I just didn't know if the work group wanted to own that possible reassessment or not.
Oh, I think that the current and future circumstances are going to necessitate your reassessment. Even just on a financial basis, that kind of money is going to make you look at it again to see if there are other alternatives.
Well, and the conversation is being held nationally.
Yeah,
It's not just here. This conversation
Absolutely.
is being held throughout this country.
right.
And it's not just now corrections and public safety that's having this conversation. It's being held now by some of your facilities, not assisted living, but I know that some of the other facilities, private facilities, are also having this conversation. And so, to me, it begs the question of whether or not we should not be a part of this conversation. It's one that states, from a budgetary standpoint and also a humane standpoint, are grappling with.
That's right. and that's last
They're grappling with the issue when you have an individual who no longer is a threat to a community, and is so debilitated that they need another option besides the prison institution. So I, would say that, it's not that we don't continue to have this conversation, because it's occurring. It's occurring nationally. I don't know if you go to a meeting and talk about healthcare and corrections, it comes up in the conversation across this country.
So what I'm hearing, just to reassess, and then Ms. Howes, is that you're suggesting we amend DA Sparks' recommendations only in the implementation line and keeping possible reassessment behind implementation, correct? Senator? Okay,
And when you're done, then I.
okay, Ms. Howes?
I'm sorry, I must have misheard. So is the recommendation at this point to state under implementation possible reassessment, and then with legislative action, none? Is that correct?
Yes, I believe that's what I was
Okay,
hearing.
and then what should the recommendation be? No change?
No change.
Okay.
And maybe no change at this time is more accurate if
Yeah,
we're,
that might be more accurate.
And then And then with the other suggestion for recommendation was that we have an ongoing conversation, or that conversation be continued, or something along those lines.
If I might clarify.
Yes, please.
My suggestion was under recommendation, even though there is no change recommended at this point, we are recommending further conversation to take place. And if there is, if that conversation is still ongoing, there really is no action under implementation.
Right.
So, I would agree with DA Sparks. Under implementation and legislative action, we're not recommending anything, but what we are recommending is further conversation to explore possibilities.
Doctor and Senator, you're okay?
I'm fine with
that?
I'm okay with that.
Okay, Ms.
Absolutely.
House?
And just for the record, I support that suggestion. I am very glad that the conversation is happening nationally. While I think it's correct to say that this committee is not recommending any action, I do want to have this group support that conversation, and I think it speaks loudly for us to say, further conversation warranted, so that we are signaling we want to be a part of that national conversation, or that we support that national conversation happening.
Great, thank you. Sheriff?
I thank Chair Boris. I think he captured it well. Further conversation, I think, is an appropriate recommendation, provided that the narrative captures what we remembered from our September 8th meeting, that we affirmed as a group no change be made by the legislature with respect to early medical release. The legislature is independently minded, all elected. You will do the best job that you do, and you think for yourselves. But from this work group standpoint, I think that's an important statement to make. And to be voracious about the recommendation and implementation, to be voracious about the implementation and legislative action, I think none is, because truly that's really where we're at. And I also don't think it takes away from this work group that we did not go further, because there are a host of stakeholders. There are more than a few considerations, which we just started to kind of peel the layers back on. So I nicely said, Fair Boris, thanks.
Great. So Sheriff, just to be clear, are you comfortable that the language that remains then in that paragraph does codify to the degree that you think it needs to our conversation around this topic?
Yes, Chair Peters, the language that you read from DA Sparks' email, I think, captured it well in the narrative.
Okay, thank you. Officer Miller?
Okay. Chair Peters, I tend to look at this, I know this is a passionate issue for a lot of people, and I've tried to look at it objectively. I think we'd be remiss if we changed anything, as far as taking it out of consideration, because we were enacted to come up with ideas to reduce medical costs. This is one of the ones that has a possibility of substantially reducing medical costs. Whether or not it's able to be acted on by the legislature, or whether it's going to be popular in the public eye, or any of that, really is, I don't see as really part of our job here, is more as we're designed to come up with ideas to put forward that the legislature can either choose to act on or not. What we recommend is they're not bound by. So I really think we'd be remiss if we didn't at least recommend that there would be a further conversation about it.
Fair enough. So with the amendments on the table, are you comfortable
I am.
with the change? Okay, great. Thank you, Officer Miller. I appreciate that. Any other comments? Representative Williamson?
Yes, this is Julie.
Oh, hi, Julie.
Can you hear me?
I can.
Okay, great. So I'm not sure, I've been looking for the right place to insert this, and it seems like this might be the right place. We had, touched a little bit on advanced directives, and given just the previous statements about, reducing costs, and yet at the same time, if we're looking at maybe not at this point in time extending an early parole release structure, Senator Bates did like the idea of having everyone do an advanced directive when they come into custody. And that way, at least, as we have people who are in custody, if something does happen, or say they at some point in time would be a candidate that seems like they would be qualified for a potential early parole release in the future, that this the choice at least of what kind of care they want has been offered to them. we have a significant number of people when offered advanced directives often choose that they want to have a different type of treatment, or they want to have maybe a natural death, and or they don't want the highest cost treatment, which we know about 30% of at least Medicare costs need to go to those last few months of life. And so this could be a potential, cost expenditure or cost savings, as well as acknowledging and allowing an individual to voluntarily select the treatment that they feel is good for. So I just wanted to put that there. Again, we weren't sure where would be best to put that in, but
Okay, thank you, Julie. I appreciate that. So what I'm hearing from Julie is she's wanting to include or have us consider a new recommendation,
Advanced directives.
or not necessarily requiring, but providing the opportunity for those individuals who are coming into our custody to have access to an advance directive. Comments?
yes.
Is that right, Julie?
They actually, if we go so far as to even saying we would highly recommend that it gets done in, when everyone comes in, if possible.
Okay,
For that option.
thank
as a
you.
requirement.
Comments? Officer Miller?
Madam Chair, is there a policy prohibiting?
No.
I don't, and I'm trying to remember, I feel like we had just a small conversation around this table around advanced directives, and I'm not remembering what Mr. Robbins shared with us. I'll look to Mr. Shoemaker and Mr. Van Valkenburg to help me recollect that conversation. Do we allow for it now?
Chair Pete?
You know the answer?
I do.
Okay, go ahead.
Chair Peters, right now we do. It's not a health services policy that everybody has an advanced directive, but everybody is afforded the opportunity to have an advanced directive.
Great. And we do that at intake?
We do that once they are diagnosed with an ailment or a condition that would require one.
Require what? One.
Let me,
Got it.
let me say,
Okay.
for the record, Jeff Van Valkenburg, Department of Justice.
Good morning, thank you.
There's a small little area in which the department would not honor the potential advanced care directives of an inmate, and that would be in an issue in which there was a purposeful
Right.
Right.
hunger strike or other demonstration which could get to a point where someone could be at risk physically. And the department has a separate confidential policy in how it deals with that, and it's a very unusual situation, but
Important for us to clarify.
as a general proposition, I understand that the department honors advanced care directives to the extent that it can.
Okay. Senator?
Question, but there's nothing currently that prohibits the department from actually being able to offer advanced directives if the person so choose to want to fill out one.
Correct, and it sounds like we are in fact engaging in that conversation with those individuals in our custody. Doctor?
Madam Chair, my understanding, though, is we only engage them when they're diagnosed with something that obviously puts them at risk. I would think that would be a part of general intake, that people are given the right to know that exists, even that they don't fill it out, and be educated about it.
In preparation for something we didn't know was coming, like a heart attack.
That's right. Just as we are promoting in general health, that your doctor let you know about advanced directives immediately, not after they tell you got 2 weeks to live.
Chair Peters.
Shoemaker?
Chair Peters, Dr. Knight Richardson, that could be part of the intake process. Never been through intake. I'm not aware of the entire process and education.
But you know, from a health services perspective, it's definitely happening.
Yes, it
it's a
is.
lot.
How about if we
Right.
do this? It would be my recommendation, especially since this is a new recommendation to the work group, that I commit Ms. McFadden to meeting with you and/or Senator Bates and share with you what our process is once I'm able to get educated on it. And then we can have a conversation offline away from this work group from that point. Ms. McFadden, does that sound reasonable?
It does sound reasonable. I appreciate you entertaining any recommendations.
Great, then we'll be sure to reach out to you and the senator and get something arranged for a conversation, okay?
Thank you.
Thank you. Anything else on the analyze possible early parole release restructure?
Madam Chair, could you copy the work group on whatever you all come up with? Because I think it's easier to sign an advance directive when you're healthy than it is acknowledging your own potential death.
When it becomes real.
When it becomes real. And I think it's important that we take a look at this and say, okay, so you're telling me that advance directives don't pertain to hunger strikes? Do they pertain to attempted suicide efforts if they're not successful? Or, I mean, I think that there's like a whole list of things that can happen in the prison environment that I'd like just to have a better sense of what's covered and
Absolutely
what's
do that, Ms.
not
Botkin.
covered.
We'll put a brief together
That'd
and
be-
email it out to the work group
That'd be great.
in
Thank
advance
you.
of my meeting with the senator. Okay,
That's the question.
thank you. So before we move on, Officer Miller?
Well, Madam Chair, I know that I'm aware of some of those cases where up in our infirmary, especially when the people are placed in hospice, where they do an advance directive for them. And I believe that we honor that.
Okay.
We always have. The problem I see with trying to do it with intake and stuff like that is that the person may come in relatively healthy and say that they don't want you to do anything, but then that attitude can change and an advance directive can go away in a blink of an eye. They can change that in a heartbeat. So it's like in a situation where they're at an end-of-life situation, then they're more likely to make a choice that they're going to stick with.
And we'll want
Whereas-
to revisit it along the spectrum.
Yeah.
Fair enough. I think that's a fair comment, Officer Miller. And I think in reality, that's what happens, right? That advance directive is an ongoing conversation with your doctor, and it should be at the Department of Corrections too. So let us look at what we're doing from a whole spectrum perspective, and we'll get that out to you as soon as possible. Okay. So before we move off of analyze possible early parole release restructure, I want to go back through the changes to make sure that we are capturing them perfectly. So I'm going to use Deputy DA Sparks' email. We will keep the first two sentences. We will strike the third sentence, which reads, to the extent that the work group desires to recommend expansion of early medical release to inmates that do not qualify for the current early release program under existing statutes, legislation is required, not rulemaking. We will strike that sentence and we will substitute that sentence with, such legislation is not recommended by the work group. Under recommendation, it will read, further conversation is warranted. Under implementation, we will strike possible reassessments and substitute that with none. And under legislative action, we will strike required if action taken and substitute with none. Any objections to those changes?
I really
Ms.
hate to
House.
sort of belabor this point, but as you read through it this last time, the takeaway I got by the last sentence is that we're recommending that the legislation not take action, sort of a proactive recommendation to do nothing. And instead, the sentiment I'm coming away with is that we have an ongoing conversation and recommend participation in a conversation. So it could be a matter of semantics here that I'm just sort of reading too finely on this sentence, but just wanted to give you my feedback on that.
Other thoughts from the work group? Director?
Would it help to augment that with none at this time?
Yes, that would help me.
which is what we said.
Which is what it said.
So under recommendation, it will read none at this time?
No, under
Or that
implementation.
On the implementation.
None at this time. So it will stay further conversation warranted under recommendation, and under implementation, none at this time.
And can I suggest a corresponding word change to that last sentence in the paragraph to say, such legislation is not recommended by the work group at this time? Or is that too
Well, you're not
suggestive?
Well, this work group will not continue, so,
Right, okay.
so at this time would not be actually appropriate.
Got it, okay.
Fair enough.
Thank you.
Anyone object to those amendments?
I'm sorry, can you then review?
I can. So the paragraph will remain as Deputy DA Sparks amended. Under recommendation, it will read, further conversation warranted. Under implementation, it will read, none at this time. And under legislative action, none.
Thank you.
Any objection? Great. Again, thank you. I appreciate the thoughtful conversation on a very difficult topic. Next, explore health incentive programs for the adults in our custody. The department is actively growing the chronic disease self-management program, which you all received an in-depth presentation on. We're growing that program across the state. We're utilizing the Stanford University-based curriculum to provide peer-based training to those with chronic health issues. Participation is a major incentive as it allows for a greater level of autonomy, creativity, and self-actualization. You know, with 93% of these adults leaving our custody at some point in time, this program is not only important for the care inside our custody, but so they understand what to do with their care and for their care once they're back into the community. We also discussed the agency's use of an outcome-based organizational transformation called CORE. I've talked to all of you about this. This is where we're mapping our organization, we're setting targets, we're measuring outcomes, we're conducting quarterly target reviews. Through that CORE process, the department is looking for health incentive options in the context of what can be measured for success and improvement. This will be greatly improved when we have an electronic health record system, so we'll be able to actually measure this in the aggregate. So the recommendation now is that the Department of Corrections is adopting this recommendation. We have, with regards to implementation, some are already in place, but more are being considered. So this is a program that will continue to grow, and that we do not require legislative action, that the department will move forward with this recommendation without legislative action required. Okay. Any changes to this part of the report? Okay. Any comments? I think that we included under this topic, at least it's in my information, an Oregonian article that highlighted the inmate health coaches and talks about this chronic disease management program. So I just draw your attention to that article. Another positive article for the Department of Corrections. I like to highlight those as much as possible because they don't happen all the time, but when they do, we greatly appreciate them. Okay. Track and measure healthcare coverage upon release. So as the Oregon health plan is expanding, as we are a state that's implementing the Healthcare Act, this is something that's very important to the Department of Corrections, and we are measuring it. So as discovered during the discussion around prison to community connections, the department is currently applying for Medicaid on behalf of releasing inmates. Tracking and measurement tools are in place, and it looks like 85% of releasing inmates are found eligible for benefits prior to release. The Department of Corrections now will be able to work quicker with an electronic health record system. I said that as if we had one. I think maybe if I keep saying it over and over again, it will happen, right? So once we have an electronic health record system, we'll be able to move even more quickly in this area.
What would I would suggest that you also include in it, because the work between the DOC and OHA has been good in its partnership, and I very much like to make certain that we talk about the good things that happen. And we've reached the 85% because there's been some really good work that has taken place between the two departments. And that's not missing, my eyes,
Good.
and so I think that my colleagues also need to hear that. The other piece of it is, and maybe the Oregon Health Authority can help us with it, but because those connectors are not just only with getting the eligibility determination and getting the Medicaid through with the Oregon Health Plan, but also that next nexus is the actual access to the services within the community. So I don't know what we've got, in order to highlight that piece, but you might want to, I'm sure it's going to vary from county to county and from region to region as to how well they're organized. But I think as much as we can let colleagues know in these reports, the better.
Great. Any objection to that recommendation? We are happy to put a paragraph or two together that talks about the positive collaboration, the great success that we have had collaborating with OHA. And I think we can even include some data points for people to read so that they can actually see the data that we're measuring it and it is successful.
Well, not only that, if you recall, that's also one of those items that we talked in terms of long-term of lowering costs. So I just like to put things out there when we're doing
good. All right, fair enough. What I'll also do is I'll ask the team that when they send out the quote-unquote final report, that they'll actually highlight for you where the changes are so that your eyes can quickly be drawn to that, so you don't feel like you're editing the whole document again.
Great.
Okay?
Thank you.
Ms. Bodkin?
I just think it's really important that that whenever it's possible, that we highlight the challenges that any citizen of Oregon, and especially inmates, are going to face when we send them back to places like Lake County. And access to health care in Lake County for anybody is challenging. And for the inmate population is going to be a huge, I think, insurmountable problem for them. And we just need to acknowledge the fact that Oregon is, by and large, a rural state where there are challenges that are difficult for law-abiding citizens to get over, much less folks who have an inherent group of challenges physically, mentally, and economically that they're going to have an even bigger problem.
Mary, could that be a part of the narrative under when we talked about incentives? And I think it's back here early on. We talk about the issue of retention of staff. I think the 50 staff, the 50 FTE, and the inability, one, to recruit, and two, what the resources that are available, or it may not be available. We're actually having the same conversation on specialty courts, and I've requested that we actually do a mapping of resources that exist or not. You're correct. This is a tremendous challenge as we talk about not only rural health, but some of the other wraparound services.
Yes, and I think it's critical that we acknowledge that we know that this is a problem for this population and that it's exacerbated by counties that are struggling just to survive economically. And I don't know, I'm not saying that we should have any answers here, but we need to acknowledge that we know this is a problem. And we talked about, well, there's special, we can make special allowances on a case-by-case basis. I don't know what the criteria is to make those special allowances. And I don't know how an inmate or their family accesses those special allowances to say, okay, you can go to Multnomah County because your health is so bad, you're going to die if we put you anywhere else. I don't know,
So just.
I'm just talking, I'm sorry.
No, that's
Let me
okay,
stop.
Ms. Botkin. So just quickly, just to clarify, it's on a case-by-case basis. It is up to what would be the receiving county
Right.
to accept and make that decision. It typically comes through the parole and probation officer to what would be the receiving county with a recommendation, be it around medical access, mental health access, being closer to family, employment opportunities, anything criterion that would make sense to improve transition. I will tell you, it only happens in rare cases. It really is the practice in Oregon to return to the county of origin.
And that's statutory. And for the person who has this county, who actually was the instrument in doing that piece of legislation, it's for a reason, as you know. It's for a reason because the major impacts were on Marion County. Because individuals, when they were released from OSP, came here, so the impact on this community. And I'm certain that, when that legislation was passed several years ago, saying that, you will return to the county in which you were adjudicated from, so.
But what we can do, Ms. Botkin, is we will, as the senator pointed out, talk about we'll expand further around the difficulty recruiting in rural counties staff, and we can highlight there the difficulty also of programs and medical access in the rural community. So we can highlight that for the report.
Thank you.
And just
Ms.
a
House?
question, I'm not familiar with the statute, but does the statute allow for some sort of neutral decision maker to do a review of that process so that if somebody does have special needs and that they're denied administratively the opportunity to go to an outside county, can they take that to a neutral decision maker?
It would be up to either the sheriff responsible
Sheriff.
for community corrections or the director of community corrections in that county. That's where it lies.
The county of origin or the county of request?
The county of origin.
Correct.
Anything else you want to
Yes.
add? Okay, great. Thanks, Sheriff.
Yes, we do occasionally host some folks on supervision from other counties, and we send some out occasionally. It doesn't happen very often, but there are compelling, normally family needs behind when those requests are approved.
But, I'm going to I think this conversation is one conversation, but the real conversation about the rural communities and the rural counties is their lack of resources and the lack of jobs. And that's, it's and Mary is correct. And that's a whole nother conversation, but I think we can point out some of the barriers, as we said in a summary. The issue of jobs and the economy is tied to rural counties. The ONC is tied to rural counties. So we need to have a greater conversation with our federal government. I've got counties like Polk County who don't have enough sheriffs, and we've got counties in southern Oregon that are being depleted of their law enforcement community. So it is a very, very serious problem in the state of Oregon.
No doubt. Thank you, Senator. Any other comments before we move on to the next recommendation? Okay, seeing none. Identify the benefits and issues with potentially performing mandatory hepatitis C testing for all adults in custody at intake. The work group learned that DOC currently provides Hep C testing only on a voluntary basis or when medically indicated, meaning when we actually see symptoms. It was suggested that there may be benefits to mandatory testing, so the recommendation of the work group was that the DOC investigate the potential benefits and issues with changing their current approach. You received a memo from our medical administrator, Steve Robbins, talking about the research that we received and why continuing on the current path made sense. And it was for a variety of reasons, but primarily because from a medical perspective, it made sense not to test until there were symptoms because we're not going to treat until there are symptoms. That being said, Mr. Robbins said that he would commit to also continuing to study to what degree adults in our custody contract chronic disease, which may have an outcome on our current position, right? So if we're able to measure that they're actually contracting it at a greater rate while in our prison, then we may need to consider consider changing our practice. Any objection to that position? Great, thank you. Legislative effort to research recruiting healthcare providers in rural parts of the state. DOC, OIA, and OHA have facilities across the state and would benefit from this. So the work group heard testimony, as Director Poxrush pointed out earlier, that recruiting, especially in rural areas, is a serious challenge to our agency. This is also the case for other public agencies, my colleague to my right, and many others. It was recommended that as agencies move forward with creating marketing and recruiting strategies, that legislative assistance may be beneficial in moving these efforts forward, meaning we may need changes to statutes that allow us to include a loan forgiveness or other options that might need legislative change. Senator?
I would like to see us strengthen this a bit, because this is actually at the heart of some of the work that's being done in rural health and others. And I think we can actually recommend that we actually put together a group that actually undertakes this task. I mean, we've all been talking about it. We can talk ourselves to death in this building. Mary's smiling. But I do think that, I don't know what language we use, but I do think that we can strengthen this. It's one that we know that is a huge problem. And some have ideas of incentivizing through loans or incentivizing various ways. Unless we bring everybody together to have that discussion, we will continue just to talk. So I would like to see if we can't put a little more meat on this, and perhaps, recommending that we actually put together a work group on it. That includes rural health and other, and Department of Ed and other experts.
And I'd be happy to work with this good senator on that, because I think it's a really good idea.
Okay. Any objection to that recommendation?
No.
So then to recap, we'll put some draft language together for you to review that actually calls a work group together that includes, at a minimum, agencies such as OIA, DOC, Rural Health, OHA, State Hospital, to explore incentives to hire folks in the rural community, that it can include examples like loan forgiveness, salary increases, etc.
And you might want to think about Wheeler's office too.
Whose office?
The treasurer.
Great suggestion.
As the largest training institute for medical providers, I offer input from OHSU as well.
Wonderful, thank you, especially given the program that you have in place right now. Okay.
And just to add, the Department of Administrative Services will need to be a part of that conversation as well, because they manage the compensation and recruitment practices for the state. And I know they're currently looking at some creative ideas around, pay and benefits for, depending on geographical areas. So this could tie well into the work that's already underway.
Perfect. Thank you, Director. I had forgotten that. Thank you. Any other changes? All right. Thank you. Okay, last but not least, moving to the last recommendation, investigate the benefits and issues of allowing tattooing for adults in custody. With known issues of diseases transmitted by tattoo needles in the community, the work group was interested in the potential impact of allowing sanctioned tattooing for adults in custody. It was recognized that this is a complex issue that impacts not only policy, but operational realities in a prison environment. The recommendation of the work group was that the DOC investigate these issues beyond the life of this work group and takes action accordingly. Our Health Services Administrator will facilitate the conversation with our policy group, which is what we refer to as our executive team at the agency. So the recommendation is under consideration, as would implementation be as well, but we're not requiring legislative action to move forward.
Quick comment, on this paragraph, is it possible, there may be different reasons for tattooing and tattoo removal, but if this is being explored, I'd like to see tattooing and tattooing removal be considered side by side. I know, especially with some gang-related and pimp-related tattoos, that it could be a benefit to the reintegration into the community to have a tattoo removed. And if it's a cost that's already underway by allowing tattoo, it'd be nice to have the pro-social element added to that.
Thank you, Ms. Howes. I actually believe it was the intent of the work group to include tattoo removal, and we missed it in the write-up. So thank you very much. OYA has had a successful program, and so I think that in order for this to make sense, it should include both. So thank you for bringing that to our attention. Any objection? Okay, so our team will make the changes that you have all recommended this morning. I promise you that we'll highlight the changes that were made in a way that will make it easy for you to edit and approve. We have, I think, a month to get this conversation wrapped up. I believe it's due to the legislature by December 1st. Is that correct, Mr. Shoemaker?
Ma'am.
So we will stay on task. I want to thank you so much for your involvement and engagement. You've given a lot of your time and energy, both at the dais and at home, reading reports and information. So I want to thank you for that. I think it's a full and rich conversation. As the director pointed out with the ASCA report, it is always so helpful to have outside eyes look into our agencies, especially an agency this large. So I appreciate that you didn't hesitate to ask the tough questions and really make us work to drive the answers. So with that, I'll open it up for any closing comments from the work group members.
I just want to echo my thanks to all of you who have participated in this conversation. When I passed this enabling legislation, it was with the hope that we got some positive recommendations and outcomes. And as you know, we weren't able to, with the first brush, we had to carry it forward with another piece of legislation, but it has been a robust conversation, and I think it's been an invaluable input. And again, I want to, where there are stories that can be told in the report to the legislature, I encourage that. Where there are obstacles or barriers, I encourage putting those in, because we only know what we know when you tell us what it is. And so, but again, I want to thank all of you for being willing to set and give your valuable time to help with this, what I think is a very, very important issue. And so I know that the good Ms. Botkins and I will continue our endeavor as it relates to
Senior citizens in prison.
Senior citizens in prison, the chronologically advantaged group.
Yeah.
Great, thank you, Senator. Anyone else?
I just want to say I learned a lot from the professionals at this table. Thank you. And my compliments to Chair Peters for moving this conversation along. You're very skilled in it.
Oh, thank you, Sheriff. I appreciate it. Anyone else? Director?
Quick comment. Again, thank you for including me in the work group. A number of recommendations are dependent on the electronic health record. And, I hope that it will be given due consideration. I know very few policy option packages see the light of day, and I hope this one does. The same with, some human capital investment. I know there was one position on case management. I hope that the recommendations will be viewed as investments rather than expenditures, because, I think what it will produce in return is far greater than what it would require to put these things in place.
On the front end. Great, thank you so much, Director. Anyone else? All right, with that, I will just say thank you once again. Really appreciate your time in this conversation. It's been a pleasure working with all of you. And with that, we will close the work group. Thank you. Thank you for everyone on the phone. I appreciate it.
I was a student fellow when I was in the Wayne Morse program.